Namaskar everyone, this is Dr. Deepthi Warikoo, Department of Physiotherapy, Dolphin PG Institute of Biomedical and Natural Sciences. Continuing with our chest clearance, today's topic is coughing. So, coughing is a protective reflex which rids the airways of secretions or foreign bodies. Any stimulation of receptors located in pharynx, larynx, trachea, or the bronchi may induce cough. An effective cough is necessary to eliminate the obstructions and keep the lungs clear. Important features concerning cough are first its effectiveness and then whether it is a productive cough or a dry cough. Airway clearance is very important part of the management of patients with acute or chronic respiratory conditions. Before going into the normal cough pump, let us see what are the different types of coughs. There could be a loud barking cough, which is often termed bovine. It signifies laryngeal or tracheal disease. A recurrent coughing after eating or drinking is because of aspirations. A chronic productive cough, which is mainly seen daily, could be due to bronchitis, bronchiectasis. Interstitial lung disease is characterized by persistent dry cough. Drugs, especially beta blockers and some other drugs, can cause a chronic cough. Nocturnal cough is an important symptom of asthma in children and young adults, and in older patients, it is due to cardiac failure. Now, when we cough, we produce something called as sputum. In normal adults, approximately 100 ml of tracheobronchial secretions are produced daily, that is the sputum. If it is excess, the tracheobronchial secretions that is cleared from the airways by coughing or huffing. It may contain mucus, cellular debris, sometimes microorganisms, sometimes blood, or some foreign particles. Now we have to assess the sputum to identify the cough. First, we have to determine the color, consistency, and quantity of the sputum. We can also grade sputum, whether it is M1 mucoid with no suspicion of pus, M2 predominantly mucoid, suspicion of pus, or P1 that is 1/3 purulent, 2/3 mucoid, P2 2/3 purulent, 1/3 mucoid, or P3 where we see that there is more purulence. Now, what is a normal cough pump? As we all know, the cough may be reflexive or voluntary. When a person coughs, a series of actions occur. We will see that in later of this slideshow. Under normal conditions, the cough pump is effective to seventh generation of bronchi. We all know there are a total 23 generations of bronchi in the tracheobronchial tree. Ciliated epithelial cells are present up to terminal bronchi and raise secretions from the smaller to the larger airways in the absence of any kind of pathology. So, what is a proper cough mechanism? So, these are the things which occur. First, during the effective cough mechanism, what we do first is a deep inspiration. Then the glottis closes and our vocal cords tighten. Then the abdominal muscles contract and the diaphragm elevates, causing an increased intrathoracic and intra-abdominal pressure, which opens the glottis and there is explosive expiration of the air. This is the generalized cough mechanism. There is positioning and patient instructions which can improve the cough effectiveness of this cough. First, we have to make sure that position of the patient for the success, especially in regarding the trunk alignment. Then maximize inspiratory phrase through verbal cues and active arm movements. Then improve the hold stage through verbal cues. Maximize the intrathoracic and intra-abdominal pressure with muscle contractions and the trunk movements. Instruct the patient in appropriate timing and trunk movements for expulsion. Make the procedure physically active on patient's part. It is very important. More patient is actively performing the mechanism, more effective it is. Now, what are the factors which decrease the effectiveness of cough pump? It is very important because we have to make sure that these factors are considered properly. First factor is decreased inspiratory capacity. Inspiratory capacity can be reduced because of pain due to acute lung disease, rib fractures, trauma to chest, or recent thoracic or abdominal surgeries. Weakness of the diaphragm or accessory muscles of inspiration as a result of high spinal cord injury or neuropathic or myopathic disease decreases a patient's ability to take a deep breath. Postoperatively, the respiratory center may be depressed as the result of general anesthesia, pain, or medication that may also decrease the inspiratory capacity. The second point, the second factor may be inability to forcefully expel the air. A spinal cord injury about T12 and myopathic disease such as muscular dystrophy can cause weakness of abdominal muscles, which are vital for strong cough. Excessive fatigue as the result of a critical illness and a chest wall or abdominal incision causing pain all can contribute to a weak cough. That we have to make sure. A patient who has pain, a patient who had an tracheostomy also faces difficulty for such things. The third point could be decreased action of the cilia in the bronchial tree. Action of the ciliated cells may be compromised because of physical interventions such as general anesthesia and intubation, or pathologies such as COPD, which includes bronchitis mainly, which is associated with the disease decreased number of ciliated epithelial cells in the airway. Sometimes we do associate smoking with such decreased action of cilia in the bronchial tree. The fourth point is increase in the amount or thickness of the mucus. Pathologies such as cystic fibrosis, chronic bronchitis, and pulmonary infections like pneumonia mainly are associated with an increase in mucus production and the thickness of the mucus. Intubation sometimes may irritate the lumen of the airways and cause increased mucus production, whereas dehydration thickens the mucus. This is very important. We should know about all this. Now, how to teach an effective cough to our patient? Because an effective cough is an integral component of airway clearance, a patient must be taught the importance of an effective cough, how to produce an efficient and controlled voluntary cough, and when to cough. It is very important. For that, first assess the patient's voluntary or reflexive cough, and then have the patient assume a relaxed, comfortable position, which is very important. For deep breathing and coughing, sitting or leaning forward usually is the best position of the coughing. The patient's neck should be slightly flexed to make coughing more comfortable. Teach the patient controlled diaphragmatic breathing, which we have been teaching in last sessions of our classes. Emphasize deep inspirations. Demonstrate a sharp, deep double cough. Demonstrate the proper muscle action of coughing, that is, contraction of the abdominals. It is very important. Patient has to contract the abdominals. Have the patient place the hand on the abdominals and make 3 huffs with expiration to feel the contractions of the abdominals. Patient can also practice making a K sound to experience tightening of the vocal cords, closing the glottis, and contracting the abdominals. When the patient has these actions together taught and he does it very properly, uh, we can see that he is able to take a deep but relaxed inspiration, which followed by a sharp double cough. The second cough during a single expiration is usually more productive. Use an abdominal binder or glossopharyngeal breathing in selected patients with inspiratory or abdominal muscle weakness to enhance the cough. That is, if necessary. We have to make sure this. Now, we have to take some precautions for teaching an effective cough. First, never allow a patient to gasp in air because this increases the work of breathing, causing the patient to feel fatigue more easily. Avoid uncontrolled cough mechanisms. It is very important because such type of paroxysmal coughing can also be very difficult for the patient. Avoid forceful coughing if a patient has a history of a cerebrovascular accident or an aneurysm. Be sure that the patient coughs while in a somewhat erect or sideline position. Now, Let us see some additional techniques which we use as physiotherapists to facilitate a cough and improve airway clearance. Assisted cough techniques which are mainly used are costophrenic assist. It's mainly the manual techniques in which hands are used to assist the coughing. First is the costophrenic technique, second is the abdominal thrust technique, third is the anterior chest compression, fourth is counter rotation. These are the manual techniques. Then we have self assisted techniques like prone on elbows with head flexion and assisting the cough, long sitting self assisted coughs, short sitting self assisted coughs, hand knee rocking self assisted coughs, standing self assisted coughs. These techniques are used to assist the patient for better cough and effective coughing. You can see the first where we are using the costophrenic assist. The patient is placing his hand on the costophrenic angles, then on the navel, the abdominal thrust. Then you can see these are the assistive cough techniques in supine positions. The placement of hand is the variations for the assist. Then you can see the counter rotation assist and the self assist like prone on elbows. Now, first let us see about the manual assisted coughs. If a patient has abdominal weakness, like the abdominals are weak, that could be as a result of mid thoracic or cervical cord injuries. Manual pressure on the abdominal area assists in developing greater intra-abdominal pressure for a more forceful cough. Manual pressure for coughing assistance can be applied by the therapist or by the patient himself. See, here is the technique where we are giving a manual assistance. Then the therapist assisted techniques. With the patient in supine semicircle position, the therapist places the heel of one hand on patient's abdomen as the epigastric area just distal to the xiphoid process. The other hand is placed on the top of the first, keeping the fingers open or interlocking them. After the patient inhales as deeply as possible, the therapist manually assists the patient as he or she attempts to cough. The abdomen is compressed with an inward and outward force, which pushes the diaphragm upward to cause a more forceful and effective cough. Like here you can see, the same maneuver can be performed with the patient in a chair. The therapist or family member can stand in the back of the patient and apply the manual pressure during the expiration. We have to make sure some precautions are taken care. Avoid direct pressure on xiphoid process during this maneuver. It is very important. The abdominal has to be compressed properly. Then we have a self-assisted techniques. While in sitting position, the patient crosses the arms across the abdomen or places the interlocking hands below the xiphoid process. After a deep inspiration, the patient pushes inward and upward on the abdomen with the wrist or forearms and simultaneously leans forward while attempting to cough. We can use splinting in it if the chest wall pain from recent surgery or trauma is restricting the cough. Teach the patient to splint over the painful area during coughing. Have the patient press the hands, or you can take a pillow over the incision to support the painful area while the patient coughs. If the patient cannot reach the painful area, the therapist should assist at that time. Humidification is also used for a good and productive coughs. If the secretions are very thick, work with the patient after humidification therapy or ultrasonic nebulizer therapy, both of which enhance the mucociliary transport system and facilitate a good and productive cough. Then tracheal stimulation, it is mainly used for pediatric patients. Tracheal stimulation, sometimes called as tracheal tickle, may be used with infants or disoriented patients who cannot cooperate during the treatment. Tracheal stimulation is somewhat uncomfortable maneuver, but it elicits a reflexive cough. The therapist places two fingers at the sternal notch and applies a circular motion with pressure downwards into the trachea to facilitate a reflexive cough. The index finger and ring finger are placed on the respective sternal notches, while the middle finger is used to stimulate the trachea. These were the techniques which are mainly used to induce coughing and have a productive cough. We have to make sure individuals who are taught cough are first taught to do it in front of you, and you supervise it. Once the patient is able to perform it properly, then he can do it at their homes also. I hope you understood the lecture. If there are any queries, they all are welcome. You can contact me. Thank you so much. Have a great day.